Hello, I want to discuss with you in this video lecture drugs for elevated blood lipids, or sometimes that's referred to as hyperlipidemia. So before we do that, I want to kind of talk a little bit about lipids. So we're going to be ultimately circling around to the drugs for hyperlipidemia, and those drugs, of course, are drugs that are going to either lower blood cholesterol and or lower triglycerides. And some are going to be better at lowering blood cholesterol, others are going to be better at lowering triglycerides, and some are pretty effective at doing both. So before we do that, I want to remind you of the chemical structure of lipids. So lipids, of course, are one of the very important biomolecules in the body. There are three really important lipids in regards to human physiology. The first are triglycerides, and triglycerides are composed of a glycerol molecule. So up here you see this is the glycerol molecule, and then three fatty acid tails. So a triglyceride is one glycerol molecule and three fatty acid tails. That's where the tri comes in. So those are super important to us, for many reasons. And probably one of the main advantages of having triglycerides around is they're a super good way to store energy in the body. So if you recall learning somewhere along the lines, most likely in either biology or physiology, that in terms of long-term energy sources, our fats are a very good long-term energy source. So we store, essentially, it's like a potential energy source. And when we think about that potential energy source, it's really the triglycerides. Then we have another really important lipid, which is a phospholipid. As you, I'm sure, so the picture of phospholipids are down here. Phospholipids have a head that's a polar head. They have a glycerol backbone, and then they have two fatty acid tails. The polar head makes this part of the phospholipid hydrophilic, meaning that it interfaces pretty well with water. The fatty acid tails, of course, are hydrophobic. So as you guys know, every cell membrane you have is made up of a phospholipid bilayer. Two phospholipids that are kind of like, their tail ends are butting up against one another, and then the heads face the water, so the heads face the extracellular surface and the intracellular surface. A super good source of phospholipids, if you're wondering, how do we get more phospholipids in our body? Lecithin is a really good source. Egg yolks are also an excellent source of phospholipids, as well as soybeans. And then the third type of lipid that I want to quickly discuss are the steroids. So this is a more diverse group that shares a kind of a structural component, and that is called a sterol nucleus. So essentially what all steroids have as a backbone is cholesterol, right? That's kind of the best known steroid. And then that cholesterol then serves as kind of a structural component of all of our other steroid hormones. So cholesterol is made in the liver. We make all the cholesterol we need in the liver. And anything that's extra has to get kind of processed peripherally. So cholesterol is also another very important component of plasma membranes. It keeps plasma membranes reasonably fluid, so they're not too rigid and they're not too squishy. It also, of course, is a building block for a lot of our essential biochemicals, including vitamin D, which is a fat-soluble vitamin, all of our bile acids, and then, of course, our steroid hormones, some of which are cholesterol, estrogen, progesterone. It's not on the picture there, but progesterone is a steroid hormone. Pregnenolone is a steroid hormone. Testosterone is a steroid hormone. So this is a really important, steroids are super important to us. And again, cholesterol, and when we start to talk about some of these drugs, this is going to come back to us because cholesterol is a very important thing, right? We're sort of conditioned to think, oh, blood cholesterol is bad, and then we should like bring it way down. But we have to kind of keep in mind that cholesterol is a very important and vital chemical or molecule in our body. And so there is good reason to have some cholesterol around. And we're going to get to that in a bit. All right, so there are our main three classes of lipids that are super important to human physiology. Here's another sort of diagram that starts to explain a little bit more about our body's serum or blood lipoproteins. So a lipoprotein is a fat and a protein, of course. And so if you look on the far side of that slide, you see on the top, you see HDL or high density lipoprotein. Underneath it, you see LDL or low density lipoprotein. And then you have VLDL, which is very low density lipoprotein. If you look at those pictures, you'll see that each one of those lipoproteins has certain constituents. Represented by purple is the protein content. So if you just eyeball those three, HDL, LDL, and VLDL, you'll see that the one that has the most purple is the HDL. So that's got a lot of protein. So it's a high density lipoprotein. In yellow, we have the cholesterol component. So you see that in the HDL, usually half of it roughly is protein. 20% of it is cholesterol. Then in the pinkish color, that's phospholipid. So in this case of HDL, 30% is phospholipid. And then in the center is triglyceride. So if you look down to LDL, you see it's got only 25% protein and 45% cholesterol. So this is low density, not very dense in terms of protein, low density lipoprotein. It's got a little bit less phospholipid and a little bit more triglyceride. And then you go to the very bottom with the VLDL, you see it only's got 5 or 10% of protein, 10 to 15% cholesterol, 15 to 20% phospholipid, and primarily triglyceride. So here we're at like greater than half, 55 to 65% triglyceride. So that's what those are. You see those measured in your blood when you get like a blood chemistry. They'll measure total cholesterol, which is all of those added together. And then they'll measure HDL, LDL, and then sometimes they'll do a ratio between the LDL and the HDL. LDL is the one that's considered the bad one, which is not the whole picture. Actually, it seems to be a very small part of the picture. There's different types of LDL cholesterol, which is kind of outside of the scope of this class, but I would encourage you to learn a little bit more about the subtypes of LDL cholesterol. I'm going to talk about one in a moment. HDL is considered the good one. It's mostly protein and soluble phospholipids. HDL is the one that's considered protective. It increases with exercise and moderate alcohol consumption, like a couple glasses of wine a week, not a day. HDL, decreases with smoking, and it's lower in diabetics. LDL cholesterol, LDL lipoprotein, low density lipoprotein, contains about two-thirds of the body's cholesterol. So remember, the cholesterol is made in the liver and it's kind of packaged. So the liver will remove as much cholesterol from the blood as it can metabolize, and whatever is in excess has to get processed peripherally. And so this is where the relationship between LDL cholesterol and potentially plaquing of the arteries comes in. So what we know is that LDL cholesterol can get dealt with peripherally by the macrophages that are kind of hanging out in our blood vessels. And so essentially macrophages are phagocytes, as you know, and they phagocytize LDL cholesterol if it's present in excess amounts. And when they do that, they get this new name and they get called foam cells, like the foam on the head of a beer. And foam cells then tend to kind of get wedged into, they sort of dive into the wall of the vessel, that inner lining of the vessel. And it looks like that might be part of the beginning of vascular damage, which then once the vessel becomes damaged, then more inflammatory cells come to the area. There's more sort of cellular debris and a lot more scar tissue forming, hence the plaquing. Now, the jury's kind of out in terms of LDL's real role in this. And it's a bit controversial at this point because we've been lowering blood lipids for so long and the LDL numbers come down, but we don't really see that many fewer cardiovascular events. And so I do think that it's something to pay attention to, but definitely it's not the only player. And that's sort of been the approach, and it's not really worked out all that great. But the drugs to lower blood cholesterol very definitely are going to go after that LDL cholesterol. And then finally, the VLDLs, those are the very low density lipoproteins that, like we said earlier, are mostly made up of triglycerides. They're really made by the liver to transport fats that are already in the body. So they're sort of fat shuttles, and they shuttle fat around. Some of that fat can get burned for fuel. The triglyceride, remember, that was our primary fuel source, or some of it can get stored actually as fat for later. All right, so the long and the short of it is that lipid molecules are hydrophobic, as we know, right? Lipid molecules, oils and waters don't mix, fats and waters don't mix. They're hydrophobic, so they've got to get transported in such a way that they can transport in the water, essentially, that makes up the majority of our body, which is in the blood. So they get transported in these kind of nice little packages for transport. And that's really what this is all about. All right, so here is a little picture about that we're going to revisit in a moment. So we're going to say, or the sort of the party line, which I don't always totally agree with. Actually, I don't agree with this very much, but the way historically we've dealt with LDL cholesterol is we say it's harmful because it's got so much cholesterol, which is true, and any excess cholesterol, so excess LDL, has to get processed peripherally, and we see tissue damage as a result of that. And that is true. Although I think there's another layer to this. Not everybody with high cholesterol has plaquing of their arteries. And some people who have low cholesterol have plaquing of their arteries. So to blame it all on LDL cholesterol, I think is not advantageous. However, to keep it as part of the picture, I think is a good idea. So definitely excess LDL cholesterol has the potential to be harmful in the face of some other issues as well. HDL, we say, is protective because, one, it inhibits the cell's ability to take up LDL cholesterol. And it also moves other lipids to the liver for breakdown. So HDL kind of takes essentially where LDL cholesterol has to get processed peripherally. HDL is able to shuttle some of those lipids back to the liver in order for them to get broken down. So it's like a sort of a reverse cholesterol transport. All right, and you can kind of see here. So remember, the liver makes cholesterol anyway. So when we have a diet that's extra, let's say in saturated fats and such, inflammatory fats, which I think inflammation is the big player here, which is kind of outside of the scope of our class, but that's a big part of this. Anyway, so somebody ingests a bunch of dietary lipids. Of course, those lipids are going to get broken down, with the bile and everything from the liver. The bile acids are going to emulsify that fat. We're going to absorb lipids. They're going to travel to the liver, like all the nutrients that get absorbed in the gut go straight to the liver, right? And then the liver builds these transporters from that point. So the drugs are going to interfere with this in some way, shape, or form. So just really quickly, the drugs that we're going to talk about, the one you're going to be responsible for knowing about for your test are the statins. But I'm going to also introduce niacin, fibric acid agents, and bile acid resins. But before that, I want to talk to you about, just really quickly, some values. So this is kind of what the standard lab lipid profiles are going to look at for values. So remember I said that on your chemistry, you'll generally see a total cholesterol reading, a low density lipoprotein or an LDL reading, a high density lipoprotein, and serum triglycerides. So let's just look at, so this is kind of a funny thing because we say this is disadvantageous, this is advantageous, but we add them all together and to get a total cholesterol number, which doesn't make sense. You're kind of adding a positive and a negative and saying that the higher the number, the worse the outcome. But, in populations that people who have high HDL and, reasonable LDL, that their total cholesterol could still be high, but it's because of the HDL. So that's just something to consider. Really, the numbers you want to look at are the LDL and the HDL and the triglycerides. And then if you do a more advanced cardiovascular panel, they'll break these low density lipoproteins into subtypes. And that's the big one. That's where the rubber really meets the road, I think. And that's where we're kind of headed with all of this, although we haven't gotten there yet because the practice of medicine lags so far behind the research. But anyway, let's get up here really quick. So total cholesterol, again, like I said, this really doesn't mean anything without the other numbers, but we say it's most desirable to have a total cholesterol of less than 200. Borderline high would be 200 to 240, and that's milligrams per deciliter. And high would be greater than 240. When we get to this LDL cholesterol, LDL low density lipoproteins, we say less than 100 for LDL is optimal, 100 to 129 is near or above optimal. 130 to 159 is borderline high, 160 to 189 is high, greater than 189 would be considered very high. The one that seems to be a really big issue, so if you were to look at the subtypes, this one, which is Lp(a), this one is the one that's atherogenic. And unfortunately, this one doesn't seem to get lowered very much with the drugs, which is a bummer because it's the problematic one. So if you have, the way I kind of approach this is if I see a high LDL number, I want to know, well, what does this actually mean? And so then I would like to see some more information. And if I see this is when I start to really worry about somebody, the Lp(a). All right. Oh, geez, sorry. The HDL, we want women to have, men to have a HDL of 40 or greater. Women to have an HDL of greater than 50. Ideally, everybody should be above 60. Remember, that's the good number. So men with a HDL of less than 40, that's considered low, and women with an HDL of 50 is considered low. So definitely try to get that up. Exercise gets that up. A good diet gets that up. Those kinds of. And then we have our serum triglycerides. Less than 150 is considered normal, 150 to 199 is borderline high, 200 to 499 is high, and anything greater than 500 is very high for triglycerides. So here are some as of the 2013, which was at the time of this recording, the most recent data I could get. We have the American College of Cardiology and the American Health Association's guidelines. So this essentially establishes 4 treatment categories for the prevention of coronary heart disease, which is, of course, the leading cause of death still in this country. So the treatment categories are 1, so we want to treat these people who have atherosclerotic cardiovascular disease already, which you would be able to see on imaging. Adults with diabetes that are I think that's supposed to say 46 to 4, I don't know what that, I think that's supposed to probably say age 40 to 75 with LDL levels between 70 and 189 milligrams per deciliter. So that's not super high, but they have diabetes. So people who have diabetes, we already know are at high risk for inflammation and vascular damage. So that's why we're worried about those people. Of course, then it would be nice to know their Lp(a). That would be super good information for those people. For me, I would definitely want to see that. Adults with LDL cholesterol of 190 milligrams per deciliter or higher, that's considered high risk. So we would consider treating those people. Adults age 40 to 75 years who have LDL levels of 70 to 189 and 7.5% or greater risk of atherosclerotic cardiovascular disease. So they're at they're at risk for atherosclerotic cardiovascular. For all of these people, the place where we start with drugs are the statins. Those are the first line therapies for all categories. So here are the drugs. The statins are first line therapy, which we see up here. What these drugs do is, so here we are. So basically what statins do is they interfere with an enzyme called HMG-CoA reductase. So HMG-CoA reductase is the enzyme necessary to run this step right here, which is to convert HMG-CoA to cholesterol. So it's essentially like one of the rate limiting steps for cholesterol synthesis. So statin drugs, you could put a big X here, bang, that's where they work. So they decrease the production of cholesterol. And they do it very good, very well. Then we have niacin. Niacin it's a B vitamin. Niacin seems to really be the best at dealing with triglycerides. So it decreases both VLDL and LDL. I'll talk more about that. We have bile acid sequestrants. What those guys do is they bind up bile acids, which makes it so more difficult to actually break down, emulsify fat, and then consequently absorb lipids into the bloodstream. So it decreases your absorption of fat, keeps it in the gut, which has some issues for the gut. And then some of our newest drugs are drugs called ezetimibe, and that drug blocks the absorption of cholesterol from the small intestine. So it's similar to the bile acid sequestrants, but it's not actually sequestering the bile acid. All right, so here are drugs that you're responsible for knowing, and these are the statin drugs. They all end in statin. So atorvastatin is one of the many examples. Lovastatin, there's all kinds of them. They end in statin. Lipitor is the brand name of atorvastatin. It's been around for a long time. There's all kinds of statins on the market. So as we know, they are going to inhibit the enzyme HMG-CoA reductase, which is the primary enzyme needed for cholesterol synthesis. So cholesterol is made in the liver, like we said earlier. There's a lot of steps involved, more than 25 metabolic steps, starting with acetyl-CoA, which you probably all remember and love dearly from the Krebs cycle. Acetyl-CoA is a 2-carbon sugar. It's produced by the breakdown of fatty acids. So starting with acetyl-CoA, ultimately then running through a series, sequential events, 25 or more metabolic steps to end up with cholesterol. And that rate limiting step here is the conversion of HMG-CoA to cholesterol, and statins inhibit the enzyme that helps that along, HMG-CoA reductase, which of course is going to result in a huge decrease in cholesterol synthesis. So what's going to happen is the liver is going to make less cholesterol, and it's going to respond to that by making more LDL receptors on the surface of liver cells. So the increased number of receptors actually then will remove additional LDL from the blood. The decrease in cholesterol doesn't appear to be permanent, and therefore patients have to stay on these drugs for life. That should be life, not live. Life, or until they can be controlled with dietary and lifestyle changes, which I will say is very possible. It is very not easy, but doable to control people's cholesterol, with the exception of a certain group, which is not very common, of a group of people that have what we call familial hyperlipidemia. So it's more of a genetic thing. So there are 7 types of statins. They're derived from, at least the 3 big ones, lovastatin, pravastatin, and simvastatin. Those guys are derived from fungi. Actually, I believe the oyster mushroom is the original source. They're all taken orally by mouth, PO, and are tolerated pretty well by most. The relatively common adverse effects are headache, abdominal pain, diarrhea, and quite common muscle or joint pain. Heartburn also is quite common. I would like to say that fatigue gets to be pretty common. And the reason for that is they also, in this process, what statin drugs do as well is they deplete our body of coenzyme Q10. And coenzyme Q10 is, if you recall, in your favorite thing, which is the electron transport chain. Coenzyme Q10 is one of the complexes in the electron transport chain. And if you remember, the whole purpose of electron transport and oxidative phosphorylation is to make ATP. So that's where the fatigue comes in. I think that's where a lot of the muscle and joint pain comes in, is the depletion of coenzyme Q10. So a severe adverse effect, which is not, we say it's rare, but it's not all that rare, is myopathy, which is like pathologic muscle pain, and rhabdomyolysis, which is kind of breaking down of the muscle, and the proteins get broken down, and that can cause fatal acute renal failure. Not very common, but definitely something to be on the lookout for, because it's not like unheard of either. So once again, statins, these are the drugs you're responsible for knowing for your test. They are the first line therapy. Everyone that needs to be treated with, because they have hyperlipidemia, they're probably going to start with these drugs. All right, so the other ones that I want to run through really quickly are the fibroic acid derivatives. Some examples: clofebrate, gemfibrozil are examples of fibroic acid derivatives. They are much better at lowering triglycerides and have a pretty nominal effect on LDL cholesterol. How they work is they activate a lipoprotein lipase, which increases the breakdown and ultimate elimination of triglycerides from the plasma. So they're getting those triglycerides out. The side effects with this is really mostly GI, like nausea, vomiting, those kinds of things. If they take it with food, they're a little bit easier to deal with. Niacin, like I said, is a B vitamin. It's actually vitamin B3. The niacin seems to be the best at lowering triglyceride levels, so it decreases the production of VLDL, which ultimately lowers blood triglyceride levels. Because LDL is ultimately made from VLDL, lower levels of LDL can be seen as well, but not as pronounced as what you're going to see with the statin drugs. Niacin, interestingly, also seems to increase HDL levels. The bummer about niacin, so if somebody has high triglycerides and you want to give niacin, the bummer is that they're going to get intense flushing. Almost everybody. So if you've ever had the misfortune of having a hot flash, you could understand this, which is like, since I'm starting to get to that part of my life now, I can explain it to you. It's like someone's lighting you on fire from the inside out. And this like incredible wave of heat rises up into your face and you turn bright red. That is what happens when you take niacin as well, which is not really that big of a deal, but it's not that much fun. And for some people, that can make them anxious. So that is something to think about. It does seem to be better if you take an aspirin first and then you take your niacin about 30 minutes later. That seems to help. Niacin also might increase blood glucose levels. So that's another reason to steer clear of niacin. They do have on the market, right? This is something you can buy over the counter. Of course, it's a B vitamin. They do have no flush niacin, which is useless. Don't waste your money on that. It doesn't do anything for anything. It's not helpful at all. It sounds like a great idea, but it doesn't do the job. All right, then we have the bile acid sequestrants. Cholestyramine is an example of an old bile acid sequestrant. Oftentimes these are combined with statin drugs if you need an additional decrease in cholesterol. What these ones do is they do what they sound like they're going to do. They're going to bind with bile acids, and they're going to form these big complexes that cannot be reabsorbed from the small intestine. So, like I said, they bind to bile acids, and they form these big complexes that can't be absorbed from the small intestine. So basically what I'm saying is you're leaving like a lot of your fat in the small intestine bound up to bile acids, which equals lots of GI distress. So you can see GI exclamation, 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 lots of GI distress. Abdominal, that's supposed to say abdominal pain, bloating, diarrhea, steatorrhea, that's fat in the stool because they're not absorbing it, and constipation. So this is, I always say, when you're listening to the drug commercials and they start talking super fast at the end, with these drugs, you're gonna hear things really quickly because this is not something anyone's gonna say slowly. Things like uncontrollable explosive diarrhea. That's a bummer, right? All the way around. And that is what will happen potentially with these bile acid sequestrants. And the other thing that we have to think about when we're not absorbing fats we also are interfering with the absorption of our fat soluble vitamins and some minerals. So people can get pretty nutrient depleted with these drugs. All right, so those are our other anti-lipemic agents. Then finally, there's this new one that I mentioned on the previous picture, showed you on the previous picture. Ezetimibe, or Zetia is the brand name. So this is kind of a new kind of a drug. It's a cholesterol absorption inhibitor. So it blocks intestinal absorption of cholesterol, fat in the jejunum by about 50%. The drug Vytorin, which I'm sure you've seen the commercials for. Vytorin is a combination of this ezetimibe and simvastatin, right? So we're seeing some major decrease in blood cholesterol and also the absorption of fat with these things. So there's some things that you would kind of expect, right? You expect to see the same sorts of symptoms that you see with the statin drugs, which are myalgia, arthralgia, that's joint pain, diarrhea, right? But then there's some strange things with these that I don't really know why they're showing up, and they're showing up in the form of of upper respiratory infections, nasopharyngitis, so an inflammation of the nasopharynx, and also upper respiratory infection. So that's miscellaneous. And then I put this as a new category, which I should have put a heading for. I don't know why I did that, but there are, so remember I said earlier that even with the addition of these statin drugs, which are really good at lowering LDL cholesterol, right? They lower LDL cholesterol like somewhere in the neighborhood of 30 to 40% in some cases, which is a huge decrease. But we're not seeing correlate with that big decrease in LDL cholesterol. We're not seeing an increase in decrease in mortality. So we're still seeing cardiovascular incidences even in these people that have this lowered LDL cholesterol as a result of the statin drugs. So like I said earlier, there's more to this picture. I think most people who really look at this would say that inflammation is a big part of it, which is where the omega-3 fatty acids come in. Omega-3 fatty acids are anti-inflammatory, among other things. They're good fats, but they are anti-inflammatory. They are known to be anti-inflammatory. And so at a dose of 180 milligrams of EPA and 120 milligrams of DHA, we see a decrease in mortality due to myocardial infarctions and stroke, which are the two most common cardiovascular diseases. So that's another thing to think about, right? There are other things other than just the statin drugs. And one place to start potentially is omega-3 fatty acids as protection. All right, so that is it for the dyslipidemics and the cardiovascular unit as a whole. So you made it through that one.